On behalf of Translumina, I, Shreya Kathuria, welcome you all to our flagship program, Interventional Insights. Before starting, I would like to give a brief introduction about Translumina. Translumina is a branch of Integris MedTech. Integris MedTech is India's leading diversified MedTech platform for global emerging markets. Apart from Translumina, Everlife is also an important part of Integris MedTech. So, with Integris MedTech, we provide a diverse portfolio which includes cardiovascular, presence in vitro diagnostics, and we provide scientific lab solutions as well. So we are number one player in scientific lab solutions in Southeast Asia and second largest stent player in India with a market share of 18% in coronary stents. We have presence in more than 2,000 hospitals and cath labs, and we directly cover 17,000 plus laboratories. And we have distribution partnership with more than 350 channels across 60 plus countries. If we look at the R&D and manufacturing, we have manufactured more than 100 SKUs, have 7 manufacturing sites in India as well as Europe, and 2 R&D centers. Moving ahead, in vascular access, in cardiovascular, we provide polymer-free stents, our drug-coated balloons. We have calcium modification devices as well. We have our in-house manufacturing facilities, which includes robust research, development, and manufacturing capabilities. Apart from that, we have strategic partnerships with companies like Shockwave, Sys Medical, Kanika, Assist, and Asahi. Moving ahead, Translumina is the interventional cardiology branch for Integris MedTech, which has presence in more than 50 plus countries. We have 5 manufacturing facilities, and we have acquired 3 companies in the span of 6 years, including Lamed and Blue Medical. We are second largest stent player and number one in among the domestic players in India, with market share of 18% in coronary stents. If we look at the product portfolio, we provide a product starting from accessing the lesion, which includes wires from Asahi. We have Thrombustor and Crusade from Kanika Corporation. We have in our vascular accessories, and we have our contrast delivery system from AC. If we look at the assessing the lesion, for that we have our IVUS system from Assist HDI, and we have options as well. For preparing the lesions, we have calcium modification devices, which includes IBL, OPNNC, Nick Nano, our in-house balloons, Optima, and balloons from Kanika Corporation. For treating the patients, we have our flagship brand, Yukon Choice. It's a sirolimus eluting coronary stent system. Apart from that, we have polymer-free stents as well, which includes Vivo ISAR and ISAR Summit. We also have our in-house drug-coated balloons called Protege. Apart from all these, we have partnered with Medinol for their Ridaforolimus eluting stent. Moving ahead, I once again welcome you all to our flagship program, Interventional Insights, where we discuss about the benefits of polymer-free technology through case presentations by cardiologists like you all. So, our today's session will be moderated by Dr. Dinesh Padole, who is a senior consultant interventional cardiologist from Wockhardt Super Speciality Hospital, Nagpur. Over to you, sir. Thank you.
Thank you, Shreya. Thank you. With that, let's begin the program, our today's program, Interventional Insights. And I would like to invite all our faculty and friends. Firstly, our chairperson, Dr. Tarun. Then our chief speaker, the international speaker from Italy, Dr. Giuseppe Di Gioia, sir. Please welcome him. And our expert speakers, Dr. Pranay Jain from Ramakrishna Care Hospital, Raipur, Dr. Adil from Kolkata Heart and Lung Institute, Kolkata, and Dr. Partha Sarthi Roy from NH West Bank, Kolkata. So without any further delay, I think I'll invite our international speaker, Dr. Joe J. P. D. Joya, to start with his presentation on shaping the future with polymer-free DES, the real-world practice and evidence. Over to you, sir.
Hello, everyone. Thanks. I would like to thank Translumina for the invitation, and also I would like to thank our moderator, Dr. Dinesh, for pronouncing my name correctly. So I'm not
Oh
sure I could
wow.
do the same with yours,
J-
but thank you. Thank you very much.
Giuseppe Di Gioia. Is it
Giuseppe
correct?
Di Gioia. Very well. That's great.
Okay.
That's great. Okay,
Thanks
so
a
if
lot.
you agree, I'll proceed to share my screen now. Oh, just a, okay. Why is it not working? Okay, so there seems to be a problem with the privacy and security, so I have to get out and get back in. If it's not a problem for you, sir, would it be possible to postpone my presentation for a
That
few
is okay, Dr.
minutes and maybe
Giuseppe Di
yeah,
Gioia.
yeah.
I want to start with the
Okay.
presentation by Dr. Pranay Jain.
Thank you. Thank you.
We'll
Okay,
start with Dr. Pranay Jain's presentation first. Vivo is in bifurcation nano crush technique. So Pranay, please, you can start with your presentation. Over to you.
so I will not be presenting a nano crush technique and all. I will be presenting on intravascular imaging and my use in calcium modification and all. So, 1 second. I would like it to be an interactive session because I will show the angiogram first and then just a discussion about the angiography and what you think is the lesion severity and the cause of the lesion, and then I will show what I have done. So the discussion part I want just after the angiogram, and then we'll proceed. Is it okay with the other panelists?
Yes, yes. Go ahead, Pranay.
Yes, yes.
So are my slides visible?
We'll have you are visible.
Yeah. So today I will be discussing one or two cases. Total 4 cases are there, but for time permission, I will be discussing at least two. So how intravascular imaging it revolutionized the therapeutic approach and the use of a polymer-free DS in the left main. So this was the first case, a 56-year male, typical chest pain with sweating of half-hour duration. The enzymes were normal, half-hour the enzymes are ought to be normal, and echo was normal. This was the ECG. Some biphasic T wave valence sign in the V2, V3, some slight depression in the lid 3, and biphasic T again in V5. This was the angiogram. So the right side was normal, circumflex was normal, some lesion in the LAD ostium. So now I want to have an opinion of our panelists. What do you think is the severity of the lesion in the osteal LAD, and what is the cause of this stenosis? Whether it is plaque rupture, erosion, calcification is there, or fibrosis is there? So opinion of other people.
It's 70 to 80% stenosis. There is no calcification. I think that probably there is fibrosis there, obviously. I think
So in
fibrotic lesion.
Cranial, if
Actually, this
are-
lesion is very difficult to be categorized right now on angio. If you see the iliocaudal, the LED, osteal LED looks pretty much okay, but in the ariocaudal or epicaudal, we can see little bit of haziness and the blockages there. As you said, I think imaging should be done in this case before deciding what exactly it is.
okay.
And
So
has said there doesn't look like too much of calcium out there.
Yeah.
So let's go ahead. Let's see what can be done.
so That's why imaging is so important in our day-to-day practice. A routine case, a workhorse case for most of us, a patient of ACS unstable angina and some hazy lesion in the ostial LAD. You can see in the areocranial also, most of the LAD is okay. Here some shelf-like thing is seen in the ostium of the LAD. Here some lesion, some eccentric lesion of 70-80% stenosis looks like haziness is there. You are not sure whether to do left main to LAD stenting or leave the patient on medical management. Now this patient I did OCT. So I will play the OCT run now. I have kept the OCT images also in the side. So the left main is a huge left main of our area of 16. And I will just pause the things which I want to mention. So this is a huge left main. So the left main is a huge left main of 16 millimeters. The EL to EL is 5.1 and the lumen area is around 5.6. Now I am going towards the bifurcation. Here the plaque starts coming. You can see clearly a calcification is there, a nodule like thing is appearing now. Still we are in the left main. This is distal part of the left main. Now I am going forward. Now you can see a circumflex artery which is arriving, and you can clearly see in the distal part of the left main there is something which is protruding inside, but still a good area of 13 millimeters square. Now again I am protruding forward. Now this is osteal LAD. If you can see a huge chunk of calcium. This is a Ultreon 2.0 OCT. You can clearly see this orange dot here. A huge chunk of nodular calcium is there. 14 mm thickness in the ostium of the LAD, just at the bifurcation left. You can say distal left main. Now I am coming to the ostium of the LAD. Now I will go to the ostium of the LAD, and this is the ostium of the LAD, an area of 2.2 millimeters square for a huge 3.6 mm LAD with a thick calcium chunk, a calcified nodule. So it is very difficult to identify a thick calcified nodule. Thickness at the ostial LAD is around 12 mm. Thickness again is 16 mm, slightly distal to the ostium, 13 to 14 mm at the distal part of the left main. So we are dealing here with a thick calcified nodule which is causing ACS situation and looks like a very simple angiogram with some hazy lesion in the ostial. So if we are not preparing this plaque well, we are going to land up in trouble. So now after seeing this osteal calcium, I thought of doing a orbital or rota, but just look at 2.5 Wolverine, it went easily. And this is the aleocaudal after cutting with Wolverine. You can now clearly see the ostium is tight, and the ramus also is now some pinching after doing the cutting balloon of Wolverine, but still the lesion has not given away. So now I took a 3 into 10 mm OPNNC, went up to 36 atmosphere, and now the lesion looks yielded. So this was an ACS scenario, so I have not taken a OCT run again after doing this OPNNC and cutting balloon to show the cracks in the ostium and all. But after seeing the OPNNC opening up well, I took the stent and see, now this is a ISAR Summit stent which I am routinely using, and look how beautifully it is opened just at the 10 atmosphere. So this was a 3.5 stent at nominal atmosphere. So post dilated with 5 into 6 mm potency because the EL to EL was around 5.2. Just nominal post dilatation with pot balloon. After that, there was some pinching of the ramus. So just routine use of DEB for me. I did a DEB 2.75 into 20. Again, repot. And this was the final result. This was the OCT. I got good areas of 16 around in left main. At that calcium point, the area was around 9. So this is the calcified area. The area I got was 8.23. And then again, after that, the areas are good areas of 10 and all. So good post dilatation, good preparation of the lesion. I got good areas and all. The patient is doing fine. This I think I did some around 6 to 8 months back, and the patient is still doing fine. Again, a thought-provoking case, 80-year female, double vessel disease, PTCA done in 2021 to LAD and RCA, diabetic, dyslipidemia. She had effort angina for at least 1 month. So classical angina, which she had prior to doing the angioplasty. And again, this was the angiogram. This is the RCA stent. A still image of the RCA stent picture I have kept. So now again, I want to interact with the panelists, what they think about this lesion severity. First thing, cause of instant restenosis, whether this is under expansion, undersizing, malopposition, neoatherosclerosis, calcified or fibrotic, or the patient is having some other issue.
Is it a drug-eluting stent? I'm
So
sorry.
this was a drug-eluting stent implanted in 2021, and
Yeah.
she came back with a focal ISR. So would you like to do it without imaging? Just looks like a simple discrete lesion, workhorse lesion for a faculty, just routine workhorse lesion. Just go predilate, whether to do a DCB or do a stent, that is a different issue. But what do you
Ideally,
think is the cause of
all
ISR?
the patients with ISR, ideally, in ideal scenario, all the patients with ISR should be evaluated with some kind of imaging first, so that we know the etiology, and then we can go ahead and decide our strategy, what has to be done. And then I
So at
think
this
Pranay, you have done the same thing.
then I have done the same thing, but at just assumption, what is the cause of ISR? Any guesses after seeing the angiogram?
It's
Well,
only four
actually,
hours.
I cannot see whether there is stent under expansion from this image.
Okay.
What I do most of the time when I don't want to use imaging, I just dilate and then I use stent enhancement techniques such as stent V's and so on with a balloon inside, just to make sure that there are no specific areas of clear under expansion. But honestly, it doesn't seem to be too much under expanded.
Yeah,
But
so rightly said, there was not a much of under expansion or undersizing. What is just as raw guess? What is the size of stent here? Looking at this is a uh,
It's a 3.5 minimum.
3.5. You're saying okay.
Yeah,
Minimum.
So this is the
3.5.
OCT after 2.0 balloon, and you can see. So here, this is a thick calcific neoatherosclerosis is the cause of ISR. You can see here clearly the stent is well opposed to the vessel wall. Thus, I have kept the images also. Stent is well opposed to the vessel wall. The stent sizing is appropriate. There is no strut fracture or any longitudinal stent deformation because it is in the middle of the stent. But there is a thick calcific neoatherosclerosis. The sizing also I have mentioned here. 51 mm was the lower side and around 57 mm, 0.57 mm at the upper part. So a thick calcific neoatherosclerosis is the cause of this focal ISR. So again, I did a Wolverine cutting balloon, then followed by 60 seconds. Then again, I took the OCT because this was not an ACS scenario. Now I got an area which was 2.2. I increased after Wolverine to 3.9. So still it is not a huge size area. So lumen area of 3.9 is still not good for me. So again, I went up with 3 into 10 OPNNC because the stent EL to EL was 3.5. I went up with OPNNC at 36 atmosphere. Again, did the OCT. And now I got the area of around 6 somewhere. You can see 6.3, 6.45 around now. So this was the right time to do a DCB. So I took a 3.5 into 20 DCB, and this was the final OCT. And this was the final result. Angiographically and OCT wise, I got an area of 7.5, 7.1. The tightest point, I got an area of 6 millimeters square, but acceptable for me because a 80-year female, I don't want to put a stent again. A well expanded stent with a good area of 6 millimeters square, I left it alone. Thank you.
Fantastic, Dr. Pranay. Well done. If anyone has any queries, I think we have 2 minutes for question and answers, or else we can go ahead with the next case.
So
Dr.
if I
Dave,
may,
sir,
my
you have
question
any?
is, what's
I
your
think, but we will
default?
also have to. I do agree with your comment that all ISR should have a good amount of imaging before you make a decision. But I think in many parts of the our country, the imaging facilities is not so easily available, and particularly when the patient is of scheme. You see, the
Correct.
imaging are not so easily possible. And in this kind of scenario, you have to apply your common sense, whether it is within few days to weeks, or whether it is around 6 months up to 6 months, or a very long one. So depending upon that, you can make some change in your strategy to deal with the situations. And as you have rightly said, many of the stentings which has been used in the past, uh, we know that the whole generation of the drug-eluting stents have changed. So now we have a much better platforms like this one, the Vivo ISR. We have also used in many situations, and we have found very gratifying results.
So rightly, sir. Vivo SR, they company usually say 3.5 can go up to 4.5. I have documented with OCT. There was no strut fracture. 3.5 I run a pot NC of 5. So
Mm.
there was no strut fracture. I'm routinely doing this with Ultima PC. I was routinely doing it with Yukon PC, which was a stainless steel platform. Still, I
Mm.
was not having any strut fracture or ISR
True.
because of that.
And even the longer length stents are also doing really very well. I had a patient, they had a PAMI, and it looked like that probably there is a not, we have not done imaging, but it was a PAMI situation. So we were also in a hurry to open up the RCA, huge RCA. We used 4 size, 48 millimeter, I think. And we had a very fantastic results. And we did a check angio after just for the sake of some vague complaint, and still doing very well.
Dr.
Fantastic.
Jiola was asking some question.
Yes.
My question was about your default strategy when dealing with this very focal in-center stenosis, because if you look at guidelines, at least European guidelines, they tell you that drug-eluting stent is better than DCBs. But actually, this is absolutely the opposite of what I find out in my practice, because it's true that if you put a stent, then maybe you have a lower rate of target lesion revascularization in the future, but you start to accrue layering of metal. And in many cases, if you have a good result after preparation, then you can choose safely to use a DCB. At least this is what we do, unless you have a distinct implication of the stent edge, or after the stent edge, where even I may argue that it's a good idea to use a DES. But in most of our restenosis cases, we go for DCB when the predilatation is efficacious. So if you have proof of good predilatation, then we almost never implant a second stent. I don't know if it's the same in your country.
So my practice is changed now for the last 7 to 8 months. Whatever bifurcations I am doing, I try to keep it provisional bifurcation and most of the time side branch DCBs. And for focal ISRs or any instant restenosis, for neotherosclerosis, it has been still the drug-eluting stent should be put, because calcific neotherosclerosis guideline also mentioned that you should put a DES. But this was an 80-year female, and if there was focal ISR, I got a good lumen area after cutting balloon and OPNNC. So I just thought of doing a short DCP of 3.5. Patient is doing fine 6 to 8 months now, no ISR till now, no complaints.
Great. Rene, regarding your first case, there was a big nodule.
Yeah.
Yeah, you achieved a great result, and with the cutting and OPNNC. Nice. That was also a
OPNNC is
nice
a
case.
great tool. So whenever
Yes,
we
yes.
talk about calcific nodule, the people will say IVL or people will say orbital atherectomy or rotational atherectomy and all. But most of the time, what I have seen, if you can break the nodule with an OPN NC, then the stent expansion is really good. That is
What
one
was
thing.
the age of that patient, first patient?
That was around 50 years something. Young patient with ACS and that too a calcific nodule. I was not expecting, but luckily I have done the OCT so I could find out.
Okay, great, great. With that, I think we should move to the second case. Dr. Joseph Pedi Joya, I think I'll hand over to you for your case now. Shaping the future of with polymer-free DES, real-world evidence.
You are on mute.
Sir, you're on mute.
Okay, can you see my screen now?
Yeah. Now the screen is visible
Okay,
and you're also audible. Yeah.
great. So I will try to move very fast before the case is just to present the stand because I think that all of you already know it and already use it. So basically, the Vivoizer stand was an answer to the natural evolution of drug-eluting stand, which were introduced in 2003, which stainless steel struts. They were very thick, and we have very poor trackability, delayed arterial healing, and problems of late and very late stent thrombosis. This got better after a few years with a second generation of DES, in which manufacturers were able to reduce strut thickness and to use alloys of cobalt chromium or platinum chromium, which were much more trackable as compared to first generation. But still, the polymer that is used to help the deployance of the drug may cause some troubles. And finally, we have newer DES which are polymer free or with biodegradable polymers. What is interesting about polymers is that they are a necessary evil, at least up to a few years ago, but they can trigger inflammatory reactions. So they may lead to delayed endothelialization and persistent platelet activation with risk of stent thrombosis and of restenosis. What is new about the Vivoizer, and I will just go very fast about this, is that it is a polymer-free stent, but in which there's a second drug, which is called Probocol, which basically is mimics the function of a polymer and helps the normal distribution of the drug into the vessel wall. So if we go just very quickly here, I just want to show you some cases. What is interesting here on the bottom right is that with conventional polymer-free stents, you have a very fast drug release, which arrives at 80% after 10 to 15 days. Whereas with the Vivoizer, it is able to mimic very well what happens with the permanent polymer stent. So the drug release is more controlled, and you reach the 80% after 30 days. So it's much more gradual release, which is actually what happens with the permanent polymer. In terms of design, it's an open cell design, so it's very nice for bifurcation. And also the strut thickness is rather thin. For smaller measures, you have 68 micron, which rises to 79 micron for intermediate measures. And this also allows to have good trackability. Of course, having very thin struts is very good because you minimize vessel trauma and you have a lower stent crossing profile. It's easier to endothelialize, but on the other hand, the disadvantages is that you have a lower radial strength, lower visibility, and a risk of stent fracture. Actually, what happens with Vivoizer, it's in the middle between ultra thin and thin, so it's able quite well to balance these two pro and cons in favor of the pros. Most important piece of evidence regarding Vivoizer comes from this study published in JCC in 2020, where actually 2,000 patients were treated with VivoEyzer, and compared to 1,000 patients treated with the sirolimus-eluting stent, and patients were followed up to 10 years. What is very nice about this study is that the safety profile of the VivoEyzer is extremely good, because as you can see, there is no significant difference between sotolimus and VivoEyzer. But what is nice is that after 10 years, you have a rate of definite and probable stent thrombosis, which is very, very low, 1.2%. And also in terms of MACE, there is no significant difference between Endeavor and VivoEyzer. There's an interesting piece of evidence in a very delicate subgroup of patients, which is the patients with diabetes. This is another publication in which the same patients as previously, they were divided into diabetic and non-diabetic. What is nice to see is that there is no difference between sotolimus and VivoEyzer for non-diabetics, neither in MACE nor in all-cause death. But there is a numerical difference. Of course, this is a trend. It's not significant, but there is a numerical difference in diabetic patients in favor of VivoEyzer as compared to durable polymer sotolimus-eluting stent. In summary, you have a stent that has more than 10 years follow-up, which is very good in diabetic patients, which has a very low stent thrombosis rate at 10 years. And this brings us to our first case. First patient, he's 71 years old, diabetic patients with other comorbidities, and he was treated with CABG in 2021. So he had a lima to the LAD and a saphenous vein graft to an obtuse marginal. What happened was the year after, the patients came to our attention with angina after mild physical effort. Bypass on the first place, but then we looked at the grafts and we saw that the lima that was supposed to be on the LAD was actually on the first diagonal branch, which was open, but with a critical stenosis at the ostium of the D1. So we had very poor retrograde filling of the LAD. And the saphenous vein graft to the obtuse marginal was also open, but there was another critical stenosis at the ostium of the obtuse marginal. So all the other marginals, they had completely no retrograde filling, so was almost useless. So these patients we decided to bring in and to perform PCI. And here you can see the first image. So I'm sure that you can recognize that there is this very ugly bifurcation stenosis of LAD and circumflex, also with a very early obtuse marginal branch. What we decided here is to perform a double stent technique, namely a clot stenting using VivoEyzer, because the patient was diabetic, first of all, and secondly, because in the left main, we wanted to minimize the rate of stent thrombosis. Just disclosure, the procedure was done with IVUS guidance. I don't have the images of IVUS here. It was a few years ago, and I don't have it. So what we did was we pre-dilated the circ and the LAD. There is an indentation of the balloons. Of course, this is a steel frame, but we went higher, very high atmospheres, and we were able to obtain a good pre-dilatation. And this is the image after pre-dilatation. So you can see the vessel is calcified, but it's also very fragile, and we have very visible dissections both towards the LAD and towards the left circumflex. We then decided to start stenting towards the circ, and we implanted the VivoEyzer 3.528, and we performed POT afterwards with a 4.5 balloon. And remember, the measure was given by the IVUS that we performed. Afterwards, we removed the wire in the circ. We rewired the LAD through the stent struts, and we opened the stent struts with a balloon first, and then we implanted another VivoEyzer 3.5 for 20 millimeter towards the LAD. So this is the result after double stenting, which is already quite nice, but of course the job isn't done. So we decided to rewire the circ. to open the stent struts towards the circ and to perform a kissing balloon inflation with two 3.5 balloons. Then we performed IVUS, and we saw that there was some under expansion of the stent in the proximal LAD. So we went back with another 3.5 balloon, and we inflated that more than 20 atmospheres there. And then we reperformed both kissing balloon and a final pot. And here you can see the final result, which was quite satisfactory in both projections. Luckily, these patients came back 1 year later to perform carotid stenting. And of course, I couldn't miss the opportunity to check the coronaries, and this was the result. So the result is quite nice. We have this 1 year follow-up, angio follow-up, but I saw the patient a few months ago at my consultation, and he's still doing fine. So after 3 years, we have very good results of this left main bifurcation stenting. Before we talk about the second case, there is also some evidence regarding the use of vivoiser in calcified lesions. In this study, this is a pooled analysis of the ISER test 4 and 5, in which what was shown using different platform is that for any platform, the presence of severe calcification significantly increased both angiographic restenosis and late lumen loss. And also in terms of events at follow-up at 10 years, you see that the higher the degree of calcification, the higher the rate of events. Of course, we know that calcium is the enemy in the cath lab. The stents that were compared in terms of outcomes were biodegradable polymer DES, polymer-free DES, and namely the vivoiser, and a permanent polymer DES. There is no significant difference between the various stents. What was nice is that numerically, at least, there was a very low rate of myocardial infarction and stent thrombosis for the vivoiser, lower than the permanent, let's say half of the permanent polymer DES. This brings us to this other patient, 55-year-old male, also with a few risk factors, but the main risk factor was family history. He had a very bad family history of CAD. So this patient was admitted in November for an NSTEMI, and he performed coronary angiography at another center, which showed 3-vessel disease. So the patient was referred to CABG at our center. So we didn't see the patients before. And this happened in November. In November, after the operation, the surgeon called us and told us, look, I was only able to put a lima to the LAD because there was too much calcium, and I couldn't bypass the circ and the RCA. So why don't you do it? So we waited for a couple months, and then we brought him in. This was the RCA. And I must say that this was just the day before yesterday. So it's all very fresh. And we looked at the lima, and as you can see, the lima is functionally occluded. So basically, this patient was operated for no reasons at all. Here you can see the left circumflex. There is a very short calcified, I would rather say occlusion rather than subocclusion of the circ, in the proximal circ. And then here in the distal part, you can see that there's a double lesion of the mid and distal LAD. So what we did, we started treating the LAD. So we performed dilatation very distally with a 220 semi-compliant balloon, and then with a 320 non-compliant balloon in the mid part. And then we treated it with a 330 sirolimus eluting balloon. And this was the final result. Of course, there is a linear dissection, but I mean, we're used to work with drug-coated balloons, and for us, this type of dissection is very safe to leave. Plus, the patient is 55, and we didn't want to put a stent there, so maybe in 20 years he can be operated again. This time, hopefully, with a reason. And then we went on to treat the circumflex. So we went right away with a rotoblator using a 1.5 millimeter burr. followed by dilation with a 320 balloon. So this is the result after predilation. You see there's an OCT catheter here that we used to actually confirm that there was calcification, very thick calcium that had been opened quite well, and that the dimension of the vessel was more or less 4 millimeter. Nevertheless, we didn't want to be too aggressive on the edges, so we took a 3.5 24 valve and you can see how it passes nicely through the calcium to go where it's supposed to go. And we implanted it, and this was after implantation. So still there is some under expansion. Of course, we expected it for two reasons. First, we pre-dilated only with a 3.0 balloon, and secondly, the vessel was 4 and the stent was 3.5. So we post-dilated it with a 4.0 balloon, non-compliant, very high atmospheres, and this is the final result. So I think it's a quite satisfying result, and we'll see how this goes. To conclude, I just wanted to share our experience on the Secure Global Registry, which is a multi-center all-comer registry on Vivoizer, together with a short dual antiplatelet regimen of only 3 months. We've included more than 100 patients now in this registry, and what I can share, at least what my opinions are about this stent, is that it's a stent which has good trackability. It has a decent radial force, means that despite the very thin struts, radial force is not too low, so we've never experienced any stent recoil after deployment. Sometimes we've experienced the necessity to have a good vessel preparation and, of course, a good post-dilation in order to expand it well. It's a good design for bifurcation. We've never had major issues with side branch occlusion or with difficult crossing of the side branch. And on the other hand, the visibility is, let's say, acceptable. But if you're used to the durable polymer competition, it's a bit lower. Anyhow, we feel it's a safe stent, and we're using it more and more. And I think it's worthy of being considered for many patients. Thank you.
So nicely done, brilliant demonstration of how imaging can help, because rightly you have documented that the circumflex size was 4 with the imaging, and then you took a 3.5 and then you post dilated with aggressively. So nicely done demonstration of DCB also, because 3 into 30, beautiful result with the DCB. Some linear dissection, but it was a TIMI-3 flow, no major dissection with a dye hanging and all. So good result.
Thank you.
So
I have
great.
one question. Yeah.
Yes,
No, no,
yes,
carry
go
on.
ahead.
Yeah. Well, it was a very good demonstration, but I had a couple of questions. First is about the use of DEB. What is your strategy in deciding? Suppose you have the vessel, the distal diameter is say 2.5 and the proximal one is 3. And generally, the DEBs we prefer is with a longer length, you see 30 millimeter, 40 millimeter. So, what is your strategy to decide the diameter of the vessel? Whether, as per like in
Yeah, that's
stents,
a
generally we decide as per the distal vessel diameter, the size of the stents. But here, say if the
yes.
distal vessel is 2.5 and the proximal one is 3, how do you decide the size of the DEB balloon?
So this is a very good question. First, we've been using DEBs much and much more in de novo lesions. And what we feel is that you need to take your time. So post-dilation should be, pre-dilation and vessel preparation in general should be very thorough. And you shouldn't be cheap on nitrates. So usually before deciding the real measure of the vessel, we perform nitrates more than once, and then sometimes we even wait 5 to 10 minutes after dilation to make sure that the vessel has reached its real dimension. Then, to be honest, we try to go one to one. It's true that sometimes we can be with very long lesions where you have a tapering of the vessel. In that case, usually we don't have a golden rule to follow, but usually it really depends on how the vessel is after predilatation. So if the vessel is already dissected and we decided to go for DCB anyway, we keep it on the safe side and we use the smaller measure. If the vessel is perfect, then we go for the bigger measure. So in this case, we would go for a 3. And what we actually take care to do is not to overexpand the DEB. So we just go nominal or even sometimes subnominal because we just want to ensure that there is contact between the balloon and the vessel wall. So we don't need to do PTCA with the DCB. That's been done with the predilation balloon. The DCB, we only use it to bring the drug into the vessel wall. So low atmospheres, and as long as the balloon touches the wall, we're fine.
Rightly pointed out, DCB should not be used to predilate the lesions. So you have to prepare the lesion well. You should have 1:1 lesion preparation with either a cutting balloon or say an NC balloon, and then you should have a full expansion of that balloon. After that, only DCB adjusts the nominal just to deliver the drug. It is never a predilatation tool.
True, true. Yeah.
Correct. I think with that we will move to the third case. I'll hand it over to Dr. Adil from Kolkata. Uses of polymer-free technology in a CTO case. Adil, you are there?
Yeah, good evening, everyone. Actually, there's some problem with my camera, but I think I should be able to share my screen. Yeah, am I able to share my screen?
Yes.
Yes.
The screen is visible. You can go ahead and start.
Okay, so I think most of the things about polymer-free drug-eluting stents have already been discussed, and there are some trials which show the beneficial effect of polymer-free stents being used, especially in complex scenarios, so as to achieve a very good long-term result to prevent instant restenosis or late stent thrombosis. So I just wanted to share, we had a case of LAD osteal CTO with a non-favorable angle, so which we did, and finally using a polymer-free DES. Our patient was a 51-year-old gentleman with no underlying comorbidity, with history of effort angina for 1 year on multiple anti-anginals. LV systolic function was normal on echo, and for these symptoms, we did an angiogram. So this is the RCA shot. The RCA was normal, and we can see that there is a retrograde filling of proximal LED rather septals from the RCA. This again the RCA shot. There's some retrograde filling of the LED. Then this was the left shot. We can say there's a large ramus, a good sized LCX, and there's retrograde filling of LED which is occluded from the ostium. And the problem of this CTO was actually the angle. The angle of origin of LED. It was exactly almost perpendicular to the ramus and left main. So the wire had to go at an angle of 90 degree and then try to pierce the proximal cap. Initially, we attempted to wire the LED after taking a workhorse wire and a microcatheter on it. The wire was continuously getting prolapsed into the ramus, which we had beforehand thought of that might prolapse into the ramus. This was the main difficulty. After using multiple wires and trying to engage the proximal cap, we took hard wire, which is we were able to engage the proximal cap, but once we were trying to deliver a microcatheter into the proximal cap of the CTO, the microcatheter as well as the wire would prolapse. Finally, we used the supercross right angled catheter. I thought that maybe I'll be able to puncture the proximal cap with the help of the angle, but again the same problem happened. Once the wire would go into the proximal cap, the wire along with the microcatheter would prolapse into the ramus. Finally, I took a guide extension catheter, 5 French, and just put it at the confluence. And from there, I engaged the proximal cap with a hardwire UB3 and then delivered a microcatheter into the proximal cap. That's very important because we want to achieve a stability, and then we can try to penetrate or go ahead with our wire. After engaging the proximal cap, the wire didn't advance. So I had to upgrade my wire to Gaia Next 2 and finally to Gaia Next 3. So I could advance the wire to some extent, but after checking from the retrograde shot, it was subintimal. So taking the wire back and again redirecting the wire after 2 or 3 attempts, redirecting the wire, I was finally able to cross the distal cap of the CTO and enter into the LED and confirmed it via because the patient was having retrograde filling from the ipsilateral as well as contralateral collaterals. So I could check the distal position of the wire from the ipsilateral side. It was in the lumen. So then advance the microcatheter into distal LED over the wire and confirm the position of the microcatheter as intraluminal. Then changed it with the workhorse wire routine pre-dilatation as routine. And after pre-dilatation, this was the IVUS run after pre-dilatation. There was significant amount of disease. We had some dissections because of the pre-dilatation. There was some calcium, especially at the osteoproximal angle. Near the origin of the this was the proximal LED, a soft fibrofatty plaque with the calcification in between. So the pre-stent minimal luminal area was around 3.2 millimeter square. This was after pre-dilatation. So then again dilated with a bigger balloon and finally took a ISR forever 3 into 44 millimeter stent because it was a long lesion. We had checked the size from the IVUS. So here there was a discussion whether we should do the ostial nailing, which I usually do not prefer. But only the problem was the confluence of the arteries was very huge, and there were two very, very large arteries arising. So in this case, I decided to go for ostial placement of the stent, keeping a wire in the ramus. I inflated the stent. This was the result after the stent inflation, post dilated with a bigger balloon. And this was the IVUS after, this was the stent. So here the stent can be expanded further. It's a bit underdilated in the proximal portion. So I could achieve in the osteoproximal area around 8 millimeter square of the stent. So as per the IVUS sizing, a post dilated with 4 millimeter balloon in the proximal portion and doing port at high pressure. This was the result after post dilatation. This was the final result, and this was the final IVAS. And near the osteoproximal LED, the area, stent area, MSA I could achieve was around 12.1 millimeter square. So a few key takeaway points that osteal CTOs are more difficult due to anatomical location and no proper back support. So choosing proper guide catheter is very important to deliver hardware. Guide extension helped in our scenario. Engaging proximal cap is very important for integrate penetration. And imaging always helps in understanding the underlying disease and is very important. Nailing the ostium versus crossover is a big discussion. I always prefer, rather most of the times prefer crossover to left main, but just because of anatomical reasons, I did the osteal stenting in this scenario. And imaging is indispensable. If you are deciding to put a stent at the ostium, then you need to be sure with the help of imaging that my ostium is nearly clean. For osteal CTO, retrograde is always an option, and we always need to be ready with our whole CTO toolkit. So a few words we already discussed. Already we know about this that permanent biocompatible polymers, they are an integral part of drug release matrix in current generation drug-eluting stents, as they ensure the release kinetics of the active drug. But there are some problems which we have come across, which has been studied in different research, different studies, that these are the inflammatory reactions to the polymer, and then during polymer erosion there is some fibrin deposition with delayed endothelialization, chronic inflammation, persistent platelet activation, and prothrombogenicity. So, in addition, the current generation drug-eluting stents which are polymer covered, which can be associated with flaking, peeling, or webbing, which may sometimes lead to impaired action of drugs. So, there has been a constant effort to decrease the amount of polymer or to replace the polymer throughout the years last decade. So we have at present available with us a polymer-free drug-eluting stent, uh, which we can use. The Theoretically, the polymer-free drug-eluting stents should be they should be absolutely these side effects, which are these adverse effects which we see with permanent polymer-coated drug-eluting stents. They should not be present there. But the one thing is there that over the long-term studies, they have not shown a very, they have not shown superiority over other permanent polymer drug-eluting stents, but we have some smaller studies which have shown definite benefit of polymer-free drug-eluting stents. So definitely it needs further research in the area, and it needs further assessment of polymer-free stents, their usage. So using them more and more, we could be more confident, and we can be more vigilant and confident about their long-term results, their added benefits. So hopefully it should make the journey of angioplasty or interventional cardiology better and better. Thank you very much.
Thank you, Dr. Adil. If anyone has any questions, please
So
go ahead.
beautiful images of IVAS you have shown. So the vessel was distally 3.5 and proximally 4. So above whole
Now,
diagonal, that was a 4 vessel.
vessel was distally around 3 millimeter, and in the proximal portion it was 4. So that's why we implanted a 3 millimeter stent and post dilated with a 3.5 millimeter balloon, and proximally did port with a 4 millimeter balloon.
So beautiful images.
Dr. Dave, sir, any questions from your end?
It's quite okay. Only thing is, I was just thinking, since there were good collaterals, even he could have attempted from the retrograde also.
Yes.
Yeah,
That
definitely.
option is always there.
For Austrial
Yeah.
CTOs, retrograde is always an option and always a
Yeah.
good option.
Because you see the ostial CTOs, it is good that you were successful, but sometimes it is difficult to penetrate right from the beginning in the ostial location.
Yeah.
You don't get a support. So from
Yes,
that
and
point of
angle was
view,
very bad.
yeah, true, true, true. But I think it was helped by probably he put a wire in the rammers, and that's why I got a little better
It,
support and
so
then
it
could
was
negotiate.
actually the guide extension helped significantly.
Yeah, okay,
Putting
true,
the guide extension in the Confluence and getting
uh,
back support from there, that's the thing which helped.
true.
Only thing after Ultimate
Okay.
Brother 3, you took a Gaia Next 2, not a Gaia Next 3, because Gaia Ultimate Brother 3 is a 3-gram wire. Gaia Next 2 is around 4-gram wire, and then Gaia Next 3 is around 6-gram wire.
Yeah, actually,
3 to 4 upgrade
ultimate.
is very less upgrade. If you are
Yeah,
upgrading
ultimate.
No, 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 no.
No, Ultimate Brother 3 actually that is
But the
definitely
next series,
almost
if you
near to
see, the
same.
grams is the technology that.
It's actually a Gaia is a more penetrating wire. UB3, if
True.
you see the tip of the wire, it is definitely 3-gram wire, but the tip is not the penetrating type of tip. It's a bit of blunt type tip. Okay, so if we just use need some amount of force, not a lot of penetration, then UB3 wire is a good option. But if we need to penetrate, then Gaias are a better option than UB3.
Gaias are prone to go into the subintimal space and go. So for an like osteal, this thing you don't want to go into the subintimal space initially. So always that is the best thing you
That's
get.
why I used UB3 initially. But once it was not able to penetrate the proximal cap, then only took a more penetrating wire.
True.
But this Asahi people, they tell us that this next series with 2 and 3, although it has a weight, I think 4 and 6 grams, but the penetrating power is as high as, I think, the pilot series. It is very high. So we have to be careful with that.
Actually, the tip is it's a tapered type tip, so it penetrates more.
Yes.
And especially at LED ostium, once we just are able to engage the ostium, after that, if we give an anti-clockwise rotation, many authors say that it increases the penetrating force to almost 1.5 times.
Correct. Correct.
The 1
Yes.
one torque
So,
transmission is very good. The control on the wire is good. This is hydrophilic coating, and so the penetrating power is 20 times more. As if you are using a 6-gram, it is around more than 20 times because that 1:1 transmission with hydrophilic coating. That is very good. But it very
so it
easily
is.
goes into the subintimal space.
Yes. So I think you should, in a CTO case, we should use wires which we are used to, with series which we are used to, rather than jumping from one company to another. I think we
That's
should
true.
have one bouquet and we should stick to it.
Whichever wire you are more confident, start with that only, rather than
Yes,
then
yes,
switching, and particularly ostial location.
yes, yes,
Dr. Giola,
yes.
your opinion on the wires you use in day-to-day practice and for CTO?
Yeah, so in this case, this was a very, I mean, I could see, of course, no microchannel, so I wouldn't go for a fielder. My choice is usually to go with a Gaia wire, starting from a Gaia second. I understand that it goes much easier into the subintimal space, but I mean, I prefer. This was a particular case because of the takeoff angle. Okay, but usually I like to go with the Gaia, and then if it goes subintimal, I leave it there and then just go parallel wire and use something else. But I prefer manually, but this is just me. I prefer manually the way of using the Gaia, with the steering and pushing rather than the drilling like one would use with the UB3. But of course, I have colleagues who prefer to start with UB3. So I think it's very personal what the colleagues was saying. So whatever you're more confident with just works. You just need to be aware of possible complications or possible outcomes, such as the wire in the subintimal space. But if you go very carefully, I don't think uh, you have to be too much worried of the Gaia wire.
Thank you, Dr. Jujep. I think with that, thank you, Adil. We'll go to the final case by Dr. Partha Roy from NH Kolkata. Partha?
Yeah. Good evening. I'm trying to share my screen. Can you see me?
Yes.
That's
Go ahead.
Okay. So I was watching all of your cases, and those were kind of very tricky situations and a very good cases. Compared to those cases, my case is very straightforward, kind of a case for you guys. So it was a 63 years old lady with chronic coronary syndrome, and she was hypertensive, and EF was 40%, and she presented with effort angina. I will start with the angio. So the angio looks like this. And there was a lesion in the LAD. I'm going to the previous one again. So the diagonal was also having a diffuse kind of a disease, and the in proximal part there was a long segment disease in the diagonal one, and the LAD had a disease of I will say like 60 to 70% stenosis, and then the RCA was totally occluded from the proximate part, and but it doesn't look that of a difficult case, because I was seeing a channel, a micro channel through the there. So first of all, we started with an run through intermediate wire. I tried to pass the wire, but it won't go. So then over the wire, I took a, microcatheter. Corsair Pro XS was the microcatheter. And one thing I did forgot to mention, that the patient was kind of a very poor patient. So anyway, the catheter was an old catheter, so I got it somehow, and then I asked for a Fielder XT, but it wasn't available. So then I had to go with the Gaia Next 2 wire, which was also an aux wire, and I could cross it after one or two attempts, and then we put another workhorse wire there, and I did pre-dilatations with 2 into 15 balloon, and then we pre-dilated the whole lesion, and then I put another body wire, because cutting balloons were off the table also, and then we did pre-dilatations with higher diameter balloons, like with the 2.5, and then we went with 3 millimeter balloons also, and then this was the result after the pre-dilatation. And then we put a Vivo ISR stent of 3.5 with 48 millimeter, and it was deployed at 12 atmosphere, and obviously I couldn't do any imaging in that scenario. and we did a post dilatation with 3.5 balloon again with the high pressure. I went up to 20 atmosphere pressure, and this was the final result. And as per angiogram, it looked quite well. And then we did wiring of LED and the diagonal, but then we first pre-dilated the LED, and first we thought we will do the LED only because it was a very poor case, so we didn't think of getting any other, balloons and all. So after wiring the diagonal, there was obviously an option for uh, giving a DCB there, but it was off the table. So we did POBA only. We did POBA with a 2 into 15 millimeter balloon, and so there was a little bit of dissection there, but could not do anything about it. And then we put a stent in the LED, which was Vivo ISR 3.5, 3.528 millimeter stent, and we 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 post dilated it with again with 3.5 15 balloons and went up to 18 atmospheres, and this was the final result. So the uh, diagonal was flowing, and the patient hadn't any complaint like chest pain or anything after the procedure. So we left the case there, and after that I have followed the patient for like 6 months, and she is doing fine. So that's pretty much it.
Thank you, Partha. Good case. Any questions?
I think it was a good demonstration of both reasons. I just had is the patient had a something like a complete heart block or severe bradycardia, or is it your routine practice to put a temporary pacing wire?
Sir, I was dealing with the CTO in the RCA. So sometimes when I deal with the RCA, I mostly I prefer a TPI there. I prefer a TPI support there, because if I had, so it was a very poor case. I wouldn't have any more things, and if the patient goes into kind of any tamponade happens or anything. So if there is any wire induced perfusion, perforation or anything, so I took a TPI support.
And do you feel that the LED stand there was a little mismatch in the distal and the proximal segment? So probably the distal end
Yeah,
was
this a little bit. I think it was overexpanded a little bit.
yeah,
Distal.
it was the distal
Yeah,
end. So do you feel
and
that you could have taken a 3.1 3.0 diameter and then post dilated, not the distal end, but the proximal one? Because Viva
yeah,
ISR can go definitely at least 1 millimeter more you can expand distance.
yeah,
So suppose you have taken three, generally you can go up to four.
yeah. I have post dilated the proximal part also with a 3.5 balloon with higher pressure, but probably I didn't have any imaging or anything, so there, I think it was a kind of a fibrotic lesion. We didn't give
Yeah.
well.
Okay. But otherwise,
Dr.
it was a good.
Giuseppe, any comments from your end?
No, I understand this was I mean the healthcare system works differently
Yes, yes. This
from
is with the
Italy.
limited
So
resources. This case has been done
yeah,
with very limited
I
resources.
understand. I understand that sometimes I mean for some patients you cannot always use what you want to use, but
Yeah.
I think there's a special skill in trying to make the best of what you have available, which is a good lessons because sometimes we are a bit spoiled, so we like to use everything all the time, but you have to prioritize. So I think that this was a very good demonstration. And finally, the result was good both in the RCA and in the LAD. I wouldn't care about the diagonal branch. I wouldn't care about the dissection or the fact that he used POBA because in the end he had at least two more open vessels than he had before. And so in the end, it was a very good result.
Stent sizing was very appropriate.
Thank you.
Results look very beautiful.
Thank you.
If we don't have any more questions, any more questions? Okay, then with that, I think we should close this wonderful session. I'd like to thank Tarun sir, Dr. Giuseppe, Dr. Pranay, Dr. Adil, Dr. Partha for the wonderful cases and wonderful discussion. I would like to thank the Translumina team, Shreya. And with that, I think it's a goodbye. Thank you, everyone.
Thank you
Thank,
everyone for
thank all of
taking
you.
out time
Thank all of
and
you.
for wonderful discussions. Thank you.
Thank you.
Thank you.